All right, hello, and welcome to Chapter 9 on behavior therapy. This chapter is broken up into two parts. It's broken up into what we think of as behavior therapy, and then the second half is broken up into what this author, Gerald Corey, calls third wave approaches, which are more of the mindfulness-based approaches. So if you've ever heard of things like dialectical behavior therapy, mindfulness cognitive therapy, EMDR, that we'll talk a little bit about on the second half. But the first half of this is going to be talking about behavior therapy. So, when we look at behaviorism or behavior therapy, you may have heard some of those words before. And you may be familiar with them if you've worked for some of the organizations that work with people who have intellectual or developmental disabilities or even autism. They might be using more behavior-based therapy. There's applied behavior analysis, ABA. If you worked in residential group homes, you might have things like token economies that are set up where the residents, like if they do certain things, they get tokens and then they can turn those tokens in for rewards. So those might be some of the things that you've seen with behaviorism or behavior therapy. So what is it? Is that they're observable theories about how people or animals learn. So basically, they're learning theories. And these came about around the time, or the first learning theory, classical conditioning with Ivan Pavlov in 1897, came about the same time that Freud was developing his psychoanalysis, his talk therapy. So this was another branch of psychology, and these were the two main psychologies that people would have come in contact. There would have been psychoanalysis or behaviorism, and they dominated psychology until the 70s, 60s or 70s. It wasn't really until cognitive therapy started to come into play that it was challenged. And now today, when you're working in organizations, cognitive behavioral therapies tend to be the therapies that are used more than psychoanalysis and maybe depending on the setting, even more than behavior therapy. Um, Behavior therapy is some of the things that you may have heard of before, but not necessarily known that they were behavior therapies. If you've ever heard of treatments for phobias or people who are afraid of like flying or afraid of spiders or heights, there are desensitization therapies that help people manage their phobias. Also could be used for panic disorders. And another way that it's also used is not with people, but with animals. So animal trainers actually get a lot of training in behavior techniques as well. So some of the characteristics of behaviorism. So remember when we were talking about psychoanalytic therapy, that it's often many of Freud's theories can't be observed or they can be difficult to study. And so there was a debate at the turn of the century in terms of which way psychology wanted to go. Did it want to go in terms of only having therapies that that could be observed, or did they want to go in this road of psychoanalysis where it could be very difficult to observe? It's difficult to observe the unconscious thoughts. It's difficult to observe defense mechanisms. And in fact, they thought that there wasn't really any way to observe those things, but you could observe behavior. So, behaviorists or behavior therapists argued for research, scientific research, which you'll hear about. Use sometimes the word empirical foundation. You also hear the word evidence-based as well, and that comes from behavior therapy. And this means that you can design research to study if these therapies work, and what's the best way to do that is through observation. There's a focus on observable behaviors. and trying to change those behaviors rather than trying to deal with the messy, subjective thoughts and feelings of a person. And it also introduced the idea of assessment, goals, and evaluation. So if you work in a mental health center, you're often doing treatment plans, you're often doing assessments to inform your treatment plans, and treatment plans have goals in them. And then at the end of that cycle, whatever, if it's 3 months or 6 months or whatever it is, you'll evaluate if those goals were met. And a lot of that is built on or comes from the behaviorists. There's also a strong emphasis on techniques. So they have a lot of different techniques that can be used. So there's extinction to try to make a behavior be extinct, and that comes from the classical theory of classical learning theory from Pavlov, and then you have the operant conditioning, which is about like reinforcement, and that it comes from Skinner as well. So there's a lot of the techniques. It's very structured and directive. So this is a therapy where the therapist is the expert, although you can introduce a more collaborative approach around it. But traditionally, behavior therapy was about the therapist being the expert. And it is very active therapy. The client is required to practice the skills in session, but also outside of session as well. And we'll talk about how that can be challenging to get clients to practice these skills outside of session. Some of the pros and cons of behavior theory. So the pros are it's evidence-based. So there's research behind it. It's been studied. It's been shown to work with various populations. It's easy to measure progress because that's just built into the nature of the treatment. And the behavior therapies can be shorter term. So if you're treating somebody for phobias, that treatment could end in as little as 4 sessions, maybe as up to 20 sessions. But that's very different if you remember with psychoanalysis taking, I think the mean was like 5.7 years of therapy. But with phobias, that's 4 to 20 sessions. ABA, if it's used, can be a bit more intensive. It can be up to 40 hours per week. For 3 to 5 years, so that can be a longer treatment. But oftentimes, behavior therapies are shorter term treatment. There's very clear techniques that are used, and it also increases clients' ability to be able to manage their behaviors in the long term. That's part of what they study in the evaluation. They'll study things like 6 months after they completed treatment, is the client still symptom free? And those are the types of things that they'll study. The cons are that there's an overemphasis on behavior. They do not focus or pay much attention to the client's thoughts or feelings, like we'll see when we start talking about cognitive therapy, or like we've seen in psychoanalysis or existential or person-centered, which is primarily focused on thoughts and feelings. It's some criticism of that it can be over-reliant on techniques. And remember, when we've seen the research, they say that technique is only accounts for about 15% of success. The rest of the success has to come from the therapist's attitude, being genuine, authentic, and open and collaborative and warm. Those things matter significantly as well. Behavior therapy, because it's not dealing with thoughts and feelings, it's not always addressing the underlying causes of a person's emotional issues. It may not be suitable for more complex mental health conditions. It can be too structured for some clients. And the big one that you'll find is that it requires motivation and discipline in order for the client to practice the technique. So in order for behavior therapy to work, you must practice. And so oftentimes people struggle with finding time in their life to be able to practice those skills. So then that diminishes its effect. If you don't practice, then it's not going to work. So it does require a significant amount of motivation and discipline on the client's part. We're going to talk a little bit about the theoretical foundations of behavior therapy. So the three main ones are classical conditioning, operant conditioning, and social learning theory. So learning theories are trying to explain how people or animals learn, how they gain knowledge, how they gain skills. Um, and in psychology, there's several major learning theories, but when it comes to behavior therapy, there are three core theories, and so those are the ones we'll pay attention to. There's classical conditioning, which was discovered in 1897 by Pavlov, and he discovered that animals learned through association. So if you think about the dog with the bell and the food, that's the association. Then in the 30s, we have B.F. Skinner, and he comes up with operant conditioning, and he says, well, in addition to people learning through association, I also can show through research that people learn through consequences and they learn through rewards. So that gets developed in the 1930s. And then in the 60s, you have what they call social learning theory or observational learning. And that is that people learn by through watching others' behaviors. That's how people learn. So those are the three main theories that we'll be dealing with. When Bandura came up with this idea that I think that there's other than because for a while people would argue that the only way people learn was through association and consequences and rewards. And Bandura is like, I don't know. I think that people learn. There's other ways that people learn as well. And so that's when he came up with social learning theory. Was controversial at first, but now has been accepted. So going back to classical conditioning and Pavlov, he was a Russian neurologist and physiologist, and he discovered through observing dogs that they learn through association. So originally what happened, if we look at picture one, there's a dog and food, and whenever a dog sees food, they automatically salivate. In his research labs, when the dogs would get food, for whatever reason, they would ring a bell. And so typically, if you have a dog and a bell rings, they do not salivate. But then, because the bell was ringing, the dog started to associate that there was going to be food when the bell was rung. So now you have all those three things, those two things connected, the dog food and the bell ringing. And so the dog will salivate. And then if you take the food away, like in number four, you'll see there's no food there, there's a bell, the dog will start to salivate just because he made that connection that when the bell rings, food shows up. So the thing that makes the dog salivate is the food. They don't normally salivate with the bell, but when they makes the connection that those two things show up at the same time, now you have the dog salivating. So this is what classical conditioning is, and there was a lot of psychologists that use this. They were just like, I can behaviorize anyone. Those were some of the things that people were saying, like I can train anyone to do anything by through this association, through this classical conditioning. But it didn't take long before people were like, oh, and we can also uncondition them as well. And they call that extinction. So extinction would be with the dog, if you ring the bell enough times and no food shows up, then the salivation will eventually go away. So there's a way to make that to stop the learning association as well. Um, so based off of classical conditioning, we have some people who start developing ideas. One notorious person in the early 1900s was John B. Watson. He advocated profusely that psychology should only study observable behavior, basically saying that talk therapy and psychoanalysis, where there was no point in studying it, you can't study it, it's not observable. Thoughts and feelings and unconscious and all of those things can't be studied, so they're not worth psychology pursuing. Um, because he believed in this, that he could behaviorize anyone, he did some unethical experiments. And so one of the unethical experiments is known as Little Albert. You can, if you want to, you can look that up on YouTube and watch. Get the gist of what this is, but basically, they took a little boy who had no fear of fluffy animals, and what they did was when a fluffy animal would appear, they would start banging and clanging and making really loud noise. And so basically, what that did is it made little Albert, through association, made him afraid of the white fluffy animal that would show up because of that association. Linking every time the cute fluffy animal showed up, there would be this loud noise. So eventually, he just would. They didn't even need to have the loud noise. He would just be afraid of animals. What they didn't do is they didn't desensitize him. They didn't do extinction and undo the link. So little Albert, who I believe died fairly young, had a pretty short life, but he was then tied with this fear and anxiety every time he saw some kind of white fluffy animal. He would be stricken with like fear and panic. And he did lots of other things as well, but that's one of the ones that you may have heard of in your psychology classes. In 1923, there was a psychologist, Mary Cover Jones, and she, through using these classical conditioning, she did help a boy overcome his irrational fears of rabbits through direct conditioning. So, what he did was he gave the boy his favorite food, which is what they would call a pleasant stimulus, every time a rabbit appeared, which for whatever reason he was afraid of. So, pleasant is boy's favorite food, unpleasant is the rabbit that he was scared of. And so every time the rabbit showed up, she would give him something pleasant. And then eventually, the little boy was able to tolerate the rabbit without having any fear. And this, building on this, we have Joseph Wolpe, or Wolpe. He creates in the 50s systematic desensitization, which is also known as exposure therapy. And that is using classical conditioning, especially the extinction, to help people who have phobias. He would also uh, pair that with relaxation techniques to treat the anxiety as well. So we would get them really relaxed and calm and in a good place, and then he would work on some of the extinction things to help people be not have those anxiety phobias or panic attacks. And so that exposure therapy is still used today. So if we're looking at classical conditioning, we're going to look at Jamie's fear of heights. So Jamie's a 10-year-old girl, has an intense fear of heights that prevents her from participating in activities such as climbing playground equipment, going to the second floor of buildings, or even looking out of tall windows. This fear causes significant distress and limits her social interactions, leading her to avoid play dates and social events. Jamie's parents are concerned about her phobia as it impacts her daily life and social development, and they've noticed that her fear escalates into panic attacks when faced with situations involving height, such as driving over a bridge. So, what type of therapy might help Jamie deal with her fear of heights? And that's going to be the exposure therapy. That therapy can help her with that, and that would be the type of referral that you would make to someone who specializes in that. And that is a specialty that is not expected of a general counselor. Most therapists are working with depression and anxiety as the primary, or relationship issues. Those are kind of the primary drivers, maybe even some work stress, grief and loss. Those tend to be the main reasons people go to therapy. When you have someone who has a phobia like that, there's usually therapists who specialize in the exposure therapy or desensitization to do that type of therapy. So if you run into someone who has that, you would refer them to a specialist, not a more generalist therapist. So moving into operant conditioning, this is another learning theory developed by B.F. Skinner, who is an American psychologist and behaviorist. He started developing this in the 30s, and his theory is that in addition to association, people or animals learn through rewards and punishment. And so he has what he calls there's a reinforcement and there's punishment. So reinforcement can be positive or negative. So positive reinforcement is you add a desirable stimulus to increase the likelihood of a behavior. So given a piece of chocolate after you exercise, or given a piece of chocolate after you do your math problems or your homework. And a negative reinforcement would be taking away um, removing an aversion stimulus to increase behavior. So you could think about an alarm clock in the morning. When you wake up in the morning, an alarm clock goes off. It's usually a really annoying sound, and you'll do anything to make that alarm clock stop, including getting out of bed and hopefully getting up for the day. So you can reinforce things through positive or through negative, usually annoying sounds. Then you have punishment, positive punishment, adding adverse stimulus to decrease behavior. So that's a very typical one that you see where a child gets scolded for misbehavior, or negative punishment, removing desirable stimulus to increase behavior. So you'll see parents doing things like taking away privileges for not following the rules or something like that. So they'll lose a privilege. So that's there's a reinforcement version and there's a punishment version of this. Operant conditioning also influence skills training. So if people are trying to learn social skills, they'll have like these social skills training classes. There's also uh, training for things like helping people, like, so if you have like a chronic medical condition, like say diabetes, there could be like a skills training group to help you get motivation to do the things that you need to do to take care of your diabetes, your chronic illness. So you'll see programs like that. Token economies, you often see those in group homes where the residents, if they do, their chores or what they're supposed to do, they'll get some kind of like token, and then they can turn those tokens in at the end of the week or the end of the month for some type of reward. Also, ABA for autism spectrum disorders. We'll use this sort of schedule to help them with develop social skills. You'll also see it used in the classroom. You'll see it used by animal trainers as well. Um, so there is a video that you can watch that will talk a little bit more about classical and operant conditioning and how it's used. If you want to learn more about that, you can look at that video. So here's operant conditioning, Carlos's behavioral challenge. So Carlos is a 7-year-old boy who has been diagnosed with autism spectrum disorder. His parents have noticed several behavioral challenges, including difficulty following instructions, frequent tantrums, and limited social engagement with peers. Carlos struggles with transition between activities and often engages in repetitive behaviors like spinning objects. Carlos' parents are concerned about his behavior, particularly his outbursts when faced with changes in routine or demands. They want him to improve his communication skills and ability to interact with other children. So, what behavior therapy would be a good fit for Carlos? Typically, would be ABA, applied behavior analysis, would be a good match for autism spectrum disorder. Moving into social learning theory, we have Albert Bandura, a Canadian-American psychologist, and in the 60s, he helped to develop social learning theory. This is where he challenged the notion that the only way we learn is through classical or operant conditioning, which is what people thought until the 60s, that was the only way that people learned. And he's just like, nope, I think people learn from other ways as well. And he was able to demonstrate that learning occurs through observing and imitating others. It influenced psychology and cognitive therapies in education, and social learning theory influenced social skills training, chronic disease self-management programs, and cognitive therapies. And there is a video in this week's Blackboard that you can watch, which will go into more detail about the social learning theory. But basically, I think it's called like the Bobo beatdown, and it's kids having like a punching a doll that wobbles, and when you punch it, and they demonstrated if kids watched an adult come in and like kick it and beat it and do t be very aggressive with it, then the kid, when the adult leaves the room, the kid will do that same behavior. Whereas before it was playing with the Bobo doll appropriately, but once it saw someone be very aggressive with it, then the kid would then demonstrate those aggressive skills, but not before they witnessed somebody else being aggressive with it. So that helped to demonstrate social learning theory. How behavior techniques can be used in the field. So assessment and goal setting, I mentioned before, behavior modification techniques, skills development, monitoring and feedback. You'll also see it in crisis intervention. So you'll see something like a patient safety plan template. So if you were working with a client that struggles with chronic suicidal thoughts, you'll hear of something called a safety plan, and this helps to kind of break out some steps in terms of what they can do. So you'll be working with the client and say, what are some warning signs? What are thoughts, images, moods, situations, or behavior that a crisis might be developing? So basically, being able to identify their trigger and early warning signs. And then they could have like, okay, so when these things happen, what are you going to do? What are your coping skills? And so you list out what you're going to do. And so the point of this is to have these skills ready before the crisis hits. So you want to work through this before the crisis hits, because oftentimes when you're in crisis, you can't access the problem-solving parts of your brain. So if you already have a safety plan in place, you're just like, oh, okay, that's right. I'm going to go for a walk, or I'm going to call this person or that. And so they'll even see, step 3 on here, people in social settings that can provide distractions. So you have like names or places, people that you can call, safe people in your life who you can ask for help. So they even talk about the people in different ways. There's the friends that you maybe don't talk to with your problems about, but they can just provide some sort of distraction for you. But then you also have the people in your life who can be more of a support for you. So that could be your therapist, that could be a close friend, that could be somebody in your support circle. Um, and then they even have it where professional agencies or people that you can contact, and then making the environment safe. So if you have suicidal thoughts and there's like a specific way that you plan to do it, making sure those objects are removed from the home so that you can't be tempted. So these are just some of the things that you might see in terms of like how a behavior plan can be used, breaking things down into concrete steps for someone to follow and help keep them safe. So that's the basics of behavior therapy. We're going to now go into what the textbook calls third wave behavior therapies, which I found interesting when I first saw this in the textbook, because I am very familiar with dialectical behavior therapy, very familiar with mindfulness therapies, and I had never heard them referred to as behavior therapies before. I never even really thought of them as behavior therapies, because they are dealing with thoughts and emotions where behavior therapy usually isn't. I thought of them more as maybe building off of cognitive therapies or cognitive behavioral therapies, but not behavioral therapies. So for whatever reason, that's how the book has classified them. So when we look at third wave approaches, I do have one on here that predates it, which is progressive muscle relaxation. And so that's not technically a third wave therapy. It was actually developed in 1929, but it's such a concrete thing that it was developed for people who have like anxiety and stress, and it's a way that you tense and release muscles in your body to help you relax. So it can be like a relaxation technique, and it's called progressive muscle relaxation, sometimes called Jacobson's progressive muscle relaxation. But it has a lot more in common with the mindfulness-based approaches than some of the classical conditioning and those types of things. It's more relaxation. So in the late 70s, early 90s, you see mindfulness-based stress reduction, which was created by John Kabat-Zinn at UMass Hospital in Worcester. That gets created in the basement of um, UMass Hospital in Worcester, and that gets created in the 1979. He's a research-based person, so he was studying his therapy, and it was shown to be very effective to help to deal with stress as well as other things. You see in 89, EMDR, eye movement desensitization and reprocessing therapy, that gets developed in the 80s. We also see DBT being developed. The DBT book gets published in 91, but she was working on that through the 70s and 80s. We see ACT, acceptance and commitment therapy, that was also being worked on through the 80s. I think that gets published in 1999, the book, but he'd been working on it for a long time. Then we see mindfulness-based cognitive therapy, so blending mindfulness with cognitive therapies together. That gets developed in 2002 to treat um, resistant depression, medication-resistant depression. That it can help with that. And then also part of the mindfulness wave is MSC, or mindful self-compassion, as well, and that gets published in 2012 and is a group-based program. So we'll be talking a little bit, going in a little bit more detail on some of these therapies. There's also some videos in this week's folder that has some sample sessions that you can watch of some of these therapies being done. Progressive muscle relaxation, you can usually just Google and get a script online. You probably could even go to YouTube and have somebody do progressive muscle relaxation if you want to experience what it is. But essentially, what it is it's almost like a body scan if you've ever done that, or even if you've done yoga, where they might do a yoga nidra at the end of it. It's similar to that, except that you're deliberately tensing and releasing your muscles. You usually start with your feet, and then work through your muscle groups all the way up to your head and your face. And he has you deliberately pay attention to when you tense the muscles, usually for about like 5, 6, maybe even up to 8 seconds, and you're observing that tension in your body. So if you want to just practice along for a second, just have your fists and then just like make fists and just tense your hands, tense them, and just pay attention to those sensations that are happening in your fist, and notice if you're doing them in your fist, if any other muscles tighten up in your body as well. And then you release, and then also pay attention to the sensations in your body when you release the tension. So you might notice the blood going back into your hands. You might notice some tingling, and then you would just do that strategically throughout your body. And then by the time you're done, you usually end up feeling relaxed, and that's exactly what it was designed for, to treat anxiety and tension. And he came up with that in 1929. The recommended dose is 20 minutes a day, and it is considered a complementary and alternative therapy. So CAM, complementary and alternative practice. It's evidence-based, and it helps with depression, anxiety, stress, insomnia, grief, pain, and burnout. In fact, with progressive muscle relaxation, when they've tested it, they've actually found that it can work faster than some of the mindfulness based therapies. As well. So, oh, and it's also been tested in workplaces for burnout. So I know that's always a concern in the field. So recommended dose 20 minutes a day to do progressive muscle relaxation. Also really great to do if you're having trouble with insomnia. It can help get you relaxed. Then we move into mindfulness-based stress reduction. So if you've heard the word mindfulness, it is because of the research of Jon Kabat-Zinn. He was a molecular biologist, but in his personal life, he practiced mindful meditation. He also practiced yoga, and he practiced yoga actually because he was doing martial arts. And when he was doing martial arts, in the beginning of the practice, the martial arts instructor had them doing yoga as the warm up, and he realized he's like, I actually like the warm up better than I necessarily like the martial arts. And then the instructor told him it was actually yoga practices that they were doing. So he was having a conversation with one of the people when he was working at UMass doing research about the patients that fall through the cracks, the patients that don't get better, the patients that have a chronic condition and there's just not a good medication or there's not a good treatment for them and they're in pain and they're suffering. And so he was talking with his medical doctor colleagues and said, what percentage of patients are that? And he's like, I don't know, like 50% of our patients fall through the cracks. And so Jon Kabat-Zinn thought he could bring mindfulness-based stress reduction to help these patients who medicine wasn't helping. So that was kind of the original um, thought in terms of developing mindfulness-based stress reduction. It's a group intervention, and it's an 8-week program. You meet 2.5 hours a week, plus there's a 1-day retreat in the middle. And you also try to get your participants to agree to practice the meditation, the mindfulness skills, 5 to 7 weeks, 5 to 7 days per week for 45 minutes a day. So imagine that you're going to class for 2.5 hours a week and you are agreeing to do a mindfulness practice 45 minutes a day for that. And not surprising, after 8 weeks of this, their evidence shows that it has reduced people's stress, their chronic pain, depression, anxiety, burnout, irritable bowel syndrome, fibromyalgia, headaches. So it's an evidence-based practice for those. And the ultimate goal is to reduce stress and increase a person's well-being. So it's an evidence-based practice. We know it works. The problem is the commitment. Are you committed to practicing 45 minutes a day? The mindfulness skills that you learn in MBSR are you're learning to stabilize your attention. And so, how do you do that? Through practices. So, they'll have a breath awareness practice. They'll have a sound awareness practice where you sit still and you listen to sounds in the room and outside of the room, body scan meditation, and even they'll have mindful movements or mindful yoga or mindful walking. So you're learning to keep your attention focused. You're learning to pay attention to how often your mind wanders, and then developing the ability to notice when your mind wanders and bring it back to be present. So that's a big part of it. Then you're also learning to accept the present moment as it is. So there's practices that help you to recognize if the moment is pleasant, unpleasant, or neutral, and recognizing that often when we're experiencing pleasant things, we try to cling to them. We want the pleasant things to last longer. When we're experiencing unpleasant things, we want to push them away, and when it's neutral, we may get bored. So learning to accept the present moment as it is without wanting to change it. You also practice learning these skills and increasing non-judgmental, what they call non-judgmental compassionate awareness. So often we can be quite critical of ourselves, and so learning to accept the moments with that non-judgmental compassionate awareness, which can be very challenging, or often can be very hard on ourselves. And then eventually, once you learn to stabilize your attention and learn to accept the present moment, learn to be present without judgment, learn to be kind to yourself, then the deeper levels of awareness can arise, and you learn a what they call an open monitoring meditation. Uh, and so that is the skills that you learn in there, and it's a lot of practice. Another one EMDR or eye movement desensitization and reprocessing. This is a developed by Francine Shapiro. She passed away in 2019, and it is blending some cognitive behavioral techniques and memory processing theories. Um, it often uses bilateral stimulation, although there's now some evidence saying that you might not even need the bilateral stimulation and to get EMDR to work. But bilateral stimulation is would be trying to get your eyes to move left to right. So when you're bringing up the traumatic memory, you would either have, there's usually like a light board, or you could follow someone's finger like left to right, and that the theory behind that was it's supposed to get the right hemisphere and the left hemisphere of the brain to like move process the trauma quicker, because often what trauma is being stuck in the moment. So if you experienced a traumatic event 30 years ago, your body and your brain still think your life is in danger even though you are safe in this moment. And so part of the bilateral stimulation was trying to get the brain to put that memory where it needs to belong, make it a memory instead of thinking that the trauma is still present now in the moment. Um, and so, while there is evidence that this therapy works, and you have to be very careful when you look up EMDR, because for a long time in the 80s and the 90s and the 2000s, it was still being studied and the results were inconclusive. But more recently, if you look at results in the last 5 years or so, you're going to see that it is approved for treating PTSD. The World Health Organization recognizes it, so you have to be careful. If you look at old articles, it says it's not evidence-based, but if you look at new articles, it says that it is. Um, and so the goal of EMDR is to reduce distress and strengthen adaptive beliefs related to a traumatic event. So it's a trauma therapy. So if you're interested in working with people who have trauma, this is definitely something that you want to look into. It requires additional training. It's very intensive training, and there's like so you have to join a support group of people who are practicing EMDR. To learn it, to really learn it. But if you're interested in trauma, this is one of the therapies that is promising. Then we have DBT, dialectical behavior therapy. So when you're trying to understand what DBT is, I like this. It's like one of the first lessons when you're teaching clients about what DBT is. We talk about this idea of wise mind, and we have two circles. We have emotion mind, which kind of can like hijack our emotions. There's no reason. We're just highly emotional, or reasonable mind, which is like fact and logic, and we're kind of like shutting down like our emotions. And so the oftentimes people who are struggling tend to be hijacked by their emotion mind, and they might over idealize reasonable mind, or and so the idea for DBT is to talk about wise mind, which is when you bring those two things together, when you bring your emotions and logic together, that's when you have wisdom. And that is the ultimate goal, to be effective. And how do we be effective in that space of wise mind? So Marsha Linehan created dialectical behavior therapy, and it grew out of a series of failed attempts using CBT. So CBT was very promising to treat originally depression and then anxiety, and there was something that was called borderline personality disorder, or people who were chronically suicidal. And so she was looking to treat that population using CBT, but it wasn't enough, and with just using CBT failed. So she started looking into other things to bring into CBT to see if it could help. To help. And so she ended up bringing in what they call contemplative practices, so the mindfulness practices. So it's got CBT techniques teaching emotion regulation and reality testing. It has contemplative practices where you learn to tolerate distress, you learn to have radical acceptance, accepting the moment as it is, and underpinning it all are mindfulness practices. There's dialectics, which is philosophical reasoning, and there's even biosocial theory that talking about how some people biologically have a disposition for emotional dysregulation. And in fact, when they start looking at epigenetics and looking at trauma and whether or not trauma can be passed down genetically, there's some evidence that if you experience trauma in the family, that that could be passed down for many generations, up to 8 generations could have this sort of emotional dysregulation because their parents and their grandparents had experienced trauma. So think about in terms of, the wars, the World War I, World War II, Vietnam War, the war with Iraq or Iran, how that is in our parents' nervous system and can be passed down. Never mind the traumas from child sexual assault or things of that nature. So, or other types of violence. So there's that. So she kind of blends all of those. And then a big portion of it is skills training. So learning mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness skills. And the goal of DBT, because we're dealing with people, or she originally was dealing with people who have chronic suicidal ideation, is to create a life worth living. What is that? What is a life worth living? There's a little even existential component to it. This is an evidence-based practice. It is the gold standard for people who have borderline personality disorder, people who engage in self-harm, people who have chronic suicidal behavior, PTSD, substance use disorders, eating disorders, depression, and anxiety. So while it was originally developed for chronic suicidal ideation, borderline personality disorder, it is also shown to be effective with a lot of other populations as well. There's also acceptance and commitment therapy that was created by Stephen Hayes. He started working on this idea in 1982. He published a book in 1999, and it differs from CBT in the fact that instead of trying to change irrational beliefs, which will make sense when we get to CBT, but instead of trying to change a person's irrational beliefs or cognitive distortions, it just asks the person to notice and accept whatever is happening in the present moment. So you see that type of mindfulness based approach, which is what you learn with a mindfulness skill. So rather than trying to change anything, just notice and accept. ACT says that suffering is a normal part of human existence, that people experience pain, grief, loss, disappointment, illness, fear, anxiety, and they are inevitable features of human life. So also sounding a lot like existential therapy, recognizing that suffering is part of life, you can't escape it. The ACT talk is has specific things that it stands for, and their theory is that suffering is created when one attempts to avoid painful thoughts and emotions. That's what creates more suffering. And so ACT teaches you to accept your thoughts and emotions, choose a valued direction, and take action. And the goal is psychological flexibility. And so it's also an evidence-based practice for anxiety, addiction, depression, psychosis, chronic pain, OCD, and other mood disorders as well. So you'll notice that you keep hearing evidence-based practice because that is the world of behavior in CBT. Is this evidence? Can we research this? Does it help? And who does it help with? Um, Moving forward to 2002, we get mindfulness-based cognitive therapy, and this is built off of Jon Kabat-Zinn's work, specifically with Mark Williams, John Teasdale, and Zindel Segal. They are people who are psychiatrists and psychologists, I believe, and they are notice that there are people who have what they call treatment-resistant depression, and they want to see if they can bring in some elements of cognitive therapy and blend them with mindfulness to help people with treatment-resistant depression. And So this is a group intervention. It's 8 weeks, 2 hours per week. There's also a 1 day long retreat. And its purpose is relapse prevention for depression. The thing about this is the evidence shows that it is just as effective as medication. So just as effective as Prozac or Effexor or the medications that there's Zoloft, just as effective as an antidepressant. However, most people can't sustain the 45-minute daily meditation practice once the group has ended. So it can be just as effective, but most people would it's easier for them to take the pill than to sustain that 45-minute practice. But this can be really good if you ever work with a client who does not want to take medication for whatever reason. This can be a great referral for them. Like, well, we do have a therapy for that. It requires a lot of discipline on your part, but we can do it. It's just as effective as taking an antidepressant. So we do have that therapy. And then building off of mindfulness, we have mindful self-compassion. This was developed by Dr. Christine Neff and Dr. Chris Germer. And this is a very specific type of practice. So when you go to MBSR, they teach this meditation a little later on, maybe even during the retreat, but it's not necessarily one of the core mindfulness meditations that you learn in MBSR, but it is a core practice if you do practice mindfulness. And so what mindful self-compassion is it's a meditation that where you see yourself, you visualize yourself, and you wish yourself three things. You wish yourself to be free from suffering, you wish yourself to be happy, you wish yourself to be healthy, and you wish yourself to be at ease. And then from there, once you wish that for yourself, you extend that out to a loved one, some or a kind person in your life. And you extend those wishes. May you be free from suffering. May you be happy. May you be healthy. May you live with ease. And you repeat those phrases to yourself for, a minute or two. And then you extend that out to a neutral person, a stranger. So if you think about like the person who delivers your mail or the person who checks out your groceries or someone in your neighborhood that walks a dog, like one of those like familiar strangers. And so you wish them those things. And then you move into the challenging part, which is wishing someone that irritates you or upsets you in some way. And they tell you when you first start to not go with like the most difficult person in your life, but someone you find mildly irritating or annoying or something along those lines. And so that could be a client, a student, that could be your coworker, your neighbor, your roommate, whoever it is. But someone who's not you don't have that's not so overpowering or it's too intense, and then you would wish them well and they would say something like at that point in time like, oh, wishing that person well and recognizing that when they are happy, when they are healthy, when they are at ease, they are less likely to engage in the more difficult parts of themselves. And then you turn that on yourself, recognizing that when you are free from suffering, when you're happy, when you're healthy, when you're at ease, that you're less likely to engage in the difficult parts of yourself as well. And then the last one is may all beings everywhere be free from suffering. And so that is the meditation that you practice. And a lot of people like that meditation because you say words, you're kind of doing a little bit of something, you're using your imagination with these people. And so they found that it increases people's happiness, so it increases well-being, optimism, curiosity, connection with others, and it decreases all the stuff that we don't want in our lives, like burnout, anxiety, depression, rumination, fear of failure, the effects of chronic pain. This is also a group format, and it's just 6 to 10 weeks, depending on the group format. And the practice, they did shorten the meditations anywhere between 5 to 20 minutes per day, figuring that people are more likely to practice if it is a shorter amount. And so this luckily Dr. Kristen Neff has a website and has like placed most of this program, and many of her meditations are available for free online if you're interested in those. And so for the takeaways of all of this, so going back to the beginning with classical operant and behavior therapy, those are the learning, the way we learn through association, rewards, and punishments. As well as observing and imitating others. The third wave approaches tend to focus on mindfulness, acceptance, and emotion processing. And the key idea with all of them is that behaviors learned, observed, and can be modified, whether that's modified through mindfulness practices or through progressive muscle relaxation, but it involves a lot of practice. So that ends chapter 9. We're going to be moving into the next chapter, which is on cognitive behavioral therapy. So we'll be talking about that next.